You're live.
Good afternoon, friends. This is George Fichette. I'm the co-director of the Transforming Chaplaincy Project and director of research here at Rush University Medical Center in Chicago. We're glad to have you all with us for the first of three webinars that we're broadcasting this winter and spring on advancing chaplaincy, learning to think and act strategically. Our session today is focused on advanced care planning. Michael Skaggs, the Director of Communication for Transforming Chaplaincy, is helping us here. Michael, let's look at the next slide. I want to introduce you to today's presenters and give you the outline for the webinar this afternoon. Beginning by giving us some background about the research on advanced care planning is Sunita Maiko. Sunita is a chaplain at IU Health in Indianapolis, and we're also very proud to say that Sunita is one of the Transforming Chaplaincy Research Fellows. Following Sunita's presentation, brief presentation, Amy Green, who is no stranger to people who are on this webinar, I'm sure, will be telling us about a pilot study that she and her colleagues did about chaplaincy and advanced care planning at the Cleveland Clinic in a pre-anesthesia clinic. So Amy is the director of the Center for Spiritual Care at the Cleveland Clinic, and we're all very proud to say that she's also the chairperson of the board of ACPE. And the next presentation will be my colleague, Aoife Lee. Aoife is the director for Mission and Spiritual Care at Rush Oak Park Hospital. And Aoife will be telling us about a project that she conducted around doing advanced care planning in a physician's office affiliated with Rush Oak Park Hospital. So we hope that the three presentations, Sunita, Amy, Aoife, will take us about 35 minutes and that we'll have 25 minutes for your questions and answers. Those of you who are used to the Zoom will know there's a Q&A box at the bottom of the Zoom screen. If you don't see it, just move your cursor a little bit across your screen and it'll show up, and that's where we'll be looking for the questions. Sunita, I'm going to turn it over to you. Michael, let's look at the first of Sunita's slides.
Yes, good afternoon. I am going to give a background about the presentation we have today. So let's looking at advanced care planning conversations and advanced directive completions. A recent systematic review of 55 studies examining the efficacy of advanced care planning interventions in different adult patient populations show that advanced care planning interventions increase the completion of advanced directives. And such interventions increase the occurrence of discussions about advanced care planning, concordance between preferences for care and delivered care. It also shows that there is likelihood to improve other outcomes for patients and their loved ones at different adult populations. This was research that was done. And the next one that I would like to talk about in the next slide is the impact of advanced directives on end-of-life care. A study that was done by Silvera and published in the New England Journal of Medicine. Surprisingly, this study was testing the association between preferences documented in advanced directives and outcomes of surrogate decision-making, which found out that compared to those who had not signed durable power of attorney in healthcare, those who had were less likely to die in hospital, and also less likely to receive all care possible. Friends, in the next one, we are looking at what is the cost of care at the end of life. Another research, wonderful research that was done by Sham and the team shows that patients who use ICU, they incur total Medicare cost of $40,000 and plus. And those who use ICU, hospital cost only was $25,929. But compared to those who don't use ICU, shows that the Medicare cost is less, is $27,160. And then hospital cost is only $12,133. what are some of the preferences of advanced care planning and advanced directives? Pew Research Center study of 1,994 American adults, which was done in 2013, found out that 35% of adults say that they have put their wishes to end-of-life decisions. This is a small percentage. Surprisingly, 1 out of 5 people age 75 and above say they have not given much thought to their end-of-life wishes. These numbers show also surprising that 1 of 5, 22%, say that they have neither written down nor talked with someone about their wishes for medical treatment at the end of their lives. And then 3 out of 10 of those that describe their health as fair or poor have neither written down or talked about their wishes with anyone. The chaplain involvement in these discussions, a research that was done by one of our colleagues, Chaplain Jane Gilland, and published in the Journal of Palliative Medicine just last year, indicates that chaplains do a lot of work, especially helping patients and their loved ones with setting their goals. 55% they indicated they do that. 46% visit to facilitate communication between patient and family and the team, and 30% help process family conflicts, while 27% indicated that they visit to discuss and complete advanced directives. These 382 chaplains who were studied show an example of what chaplains do, and as we are going to continue hearing from Amy, we are going to learn more about how chaplains get involved. Next is Amy, my colleague.
Sunita, thank you very much. Friends, we recognize it's a very quick overview, but I want to let you know that there is a substantial body of research that suggests that advanced care discussions make a difference in the care people receive. And when people get aggressive care, it's a lot more expensive. And if they don't want it, having advanced care, advanced directives and advanced care planning discussions can reduce the likelihood that they will receive that. We don't have a lot of great information about chaplain involvement in these discussions, but as Sunita showed you, there's some evidence that chaplains are spending a lot of time in some contexts helping people think about their wishes for care at the end of life and documenting those wishes. But actually, intensive chaplains projects where chaplains have kind of intentionally gone in and worked on trying to help people discuss their wishes and document them. We don't have a lot of published material about that, but we have 2 great case studies here. Amy, why don't you tell us about work you and your colleagues did at the Cleveland Clinic?
Okay, thank you. Glad to be here today. You can flip to the first slide. So this came about somewhat spontaneously after a couple of years at the Cleveland Clinic. We had been working as an enterprise. A large group of people had been working on advanced directive overhaul and trying to align a lot of different things. And out of that grew, the person in charge of that was a Dr. Shlomo Koifman, a radiation oncologist here. And over time, he began to notice that a lot of the problem with people completing these advanced directives, they had tried to run several pilots, and the best they had at that point was, I think, 40% completion. And he's a person of faith. He knew me personally. We're good colleagues. And so he reached out to me because he was aware of the fact that it wasn't difficult to obtain if the caregiver had comfort with the subject and also had a concise method. And so he approached me and said, hey, would you be willing to run a quick pilot? So we didn't have the onboarding that we would have had if we'd run an official pilot, but it was exciting that we got the chance to jump in there and show that we could do something. So in the summer of 2016, this is again the point that the chaplains we're comfortable with this. We deal with death all the time. We deal with difficult situations. I'm preaching to the choir now. And so this was the biggest reason why Dr. Koifman felt like we could pull it, make a difference. Next slide, please. Thank you. So one of the things we did was they wanted to run this pilot in one of our smaller regional hospitals. We have 8 smaller regional hospitals in the Cleveland area, aside from our 1,400 bed main campus. And one of the small hospitals has a pre-anesthesia clinic, and that seemed like a good sort of small contained place to try to do a pilot. And so we actually decided that we would distill this 12-page Ohio power of attorney document into the 4 absolute basic elements that absolutely had to be done. And then we also decided to separate it out from the living will. And I can talk more about that in the question and answer time if people are interested. But we felt that getting that the urgency to get the surrogate nailed down and placed in the electronic record was going to give us a whole lot more forward motion on this than anything else. We sent the living wills home with them and said, it's very important that you talk to your power of attorney about your living will wishes, and that's a longer discussion, and you're going to need to set some time aside. And we gave them resources like the Conversation Project and other things, and we gave our own phone numbers out and spiritual care numbers to say if you need help with this, if you want to make another appointment when you come back. But we got it separated out so that we could get it done more quickly. And most people were able to say it wasn't as threatening because it didn't necessarily end up being about end of life. Our common phraseology was, let's say you're under anesthesia longer than you need to be, and we want to make sure we're talking to the right person about what you want. And that tended to make it seem a little less frightening to people. We also came up with some very basic scripting. So part of it was we would say, as part of today's visit, we want to discuss proactive decision-making before your surgery. Again, just in case, maybe you're under anesthesia longer than we planned. You know, who do you want to answer all our questions for you on your behalf? Who knows what you want and will speak for you? We want to be sure that we know who you want to speak for you if you cannot speak for yourself. A lot of people didn't know that there was a legal order of that we have to call upon for information if the person hasn't named that power of attorney. And when they found out that, say, an ex-spouse who wasn't legally divorced from 20 years back might have life-deciding powers over them, they were pretty ready to clean that up and have a person that they had chosen be the person they signed. We said it's decision-making insurance. We didn't even talk still about so much about end of life, although we weren't lying about it. If they said it was end of life, we said yes. If something went terribly wrong and you were incapacitated for a very long time, maybe permanently incapacitated, what would you want? Make sure that we have the right person to be answering the questions on your behalf. The other part was we could honestly say it only takes about 5 minutes to complete it, because that's really true. And we found we really could do that without skipping over things and without pushing anybody too fast. We could walk them through it. We had time for questions. There were remarkably few of those. And then we could go take it, Xerox it, scan it, get it in the Epic record, and get the originals back to them before they even needed to walk out the door. Also, we told them you can change it or cancel it or update it anytime. If you need to change it, that's no problem at all. So in the pilot, as I said, the pre-anesthesia clinic was in a 150-bed regional hospital, one of our smaller hospitals. It was downtown Cleveland. It was the same week of the Republican National Convention, and there were all kinds of barriers to. It was like we couldn't have picked a worse week in some ways in terms of just the chaos of the general area, and the clinic itself was being renovated, and a lot of their regular staff was on vacation. We did not have a place to work. They originally sort of stuck us in a little office area, but we realized people were not going to come to us because, again, the front end people were not necessarily comfortable with this. And if they ask about advanced directives, which sometimes they do in the flow chart of admission, it's more like, do you have one, yes or no? There's no follow-up, or would you like to do it? And there certainly wasn't much sense of, we think this is really important and we're going to make it really easy for you. There was definitely not that. So after I was the first one on the first morning, I and 4 of my chaplains took a 4-week period, and each of us roughly took 1 day of the week to go down to this other hospital and just be available for this, for the length of the workday. And after about an hour, I realized nobody's coming down here. So I took my clipboard and I ran up front, and I sat in the waiting area, and I talked to the front end staff, and I said, you know, is it okay if I just set up in the corner over here and offer this to people? Because it wasn't a big waiting area and it wasn't crowded, and we could still be private. I made sure we were out of range of other people listening. It was easy to do. And people were quite open to it. And as you'll see, we were more successful than we even dreamed. As I said, we separated out the HCPOA from the living will. We made the living will optional in that moment. Almost no one elected to go through the whole living will at that time, even though we gave them that choice. And it wasn't actually, it kind of adjusted the whole time because the place was in utter chaos. The bottom line to that is we went wherever the patient was. So after a while, some of the front end staff, some of the practitioners kind of got into it. They could see that we were having great success. I implemented a kind of playful contest between me and my colleagues that was not obvious to the patient, obviously, but to just sort of make it more, let's just really try to do this and see where we get. And so the practitioners would become much more warm to the idea. They saw that it was not upsetting the patients. They saw that the patients wanted to do it, and that it was actually quite a service to them to get this done quickly and to get it scanned into their charts and get it back to them. And they really could see for themselves that it was not upsetting anyone and that they were really glad to handle it. So they began to say things like, they would let us go into the exam room while the patient was in there. We would knock and say, while you wait for your practitioner, do you mind if we come in? Because it was a lot of physician assistants sometimes, medical assistants, it might be the nurse. But before they would go in, they would say, if you want to talk to them now while I'm looking at the chart before I go in, you're more than welcome. And we would take that opportunity. So we were just super flexible and took our clipboards and our short speeches, and that's what we did. I think on the next slide, you'll see that we saw 163 patients that week. And we got 148 of them to, we started out with 91% of them did not have a healthcare power of attorney. Many of them said that maybe they did, but they weren't sure. Maybe it's at home. I think the standard answer to that on the front end for most admissions desks is to say, well, bring it the next time you come. And what we decided to do was say, you know what, why don't we do a new one? It'll only take about 5 minutes. And the telephone numbers may have changed. When's the last time you did it? One elderly woman said to me, oh, I definitely want a new one. It was my sister, and I don't want her to do it. And she was there with her granddaughter, and she really wanted to change it. And so we offered to just do a new one for anyone who said they thought they had it, but maybe they couldn't find it, or maybe they'd bring it. And that also really helped. It seemed faster to just do a new one. A lot of people didn't understand how simple they are now. People still think they have to do a notary public or a lawyer, or there's still a lot of misunderstanding about what it is and what is required to make it legal. So that was part of our short speech, and part of what we were able to help them realize was that we ourselves could be one of the signatories, one of the two witnesses, and that we would get one of their nurses or one of the people who had signed them in at the front desk, who knew them, had seen them before, and kind of reassured them that we were above board, and that we would have their witnesses signed and sealed and delivered. Even our addresses as witnesses were listed as Cleveland Clinic employees, and I think that helped.
Amy, just a quick reminder that
Yep,
we're going to kind of get to the results here.
Yep. And so we had a 92% success rate of the people who filled it out, and who also got not just filled them out, but got them scanned into their Epic charts before. They actually weren't scanned in before they left, but they were put in a place where they would be scanned in, and they got scanned in later, and we followed up. So we could assure them when they left with the originals in hand that they would be in their files, in their charts. I think that's the main points I wanted to make. Again, we found that they were super pleased with how easy it was, and very surprised that that was all it took. I think most people were resistant to it because they were thinking back 10 years ago or whenever, when it was just a lot more cumbersome and laborious and not as easy to understand the language. Again, other healthcare workers started to help out and get less reluctant when they saw that patients were really open to it and appreciative of it, and that we could do it very quickly. And they helped out in ways that we hadn't really expected. So I think that's the main points I wanted to make, and then I can wait for questions.
I think there's one more slide for you, Amy.
Is that right?
Yeah, there it is.
Yes, so I really want to make the case that I think this took a collaboration between a physician and us. The physicians, it was his idea to try us out, and I was so grateful to him for giving us that opportunity. It was kind of like, I felt like understudies in a play where the stars, you know, get sick and we get our chance, you know, and we got our big chance to go out there and show what we could do. And his support was certainly the only reason we got that option. And I think it really shows that we are very good at this, and we ought to promote ourselves and sell ourselves. I find that the administration is more and more realizing how much the importance of having this higher compliance in the medical record. And the word is sort of getting out that chaplains can help with this, that we are very good at it. There's research to show, there's anecdotal evidence, and there's lots of relationships with physicians that just know we get this and we know how to do it, and we're available to do it. So that's my, you know, my sermon, my evangelism is we can affect the bottom line by being able to help move the needle on this pretty significantly, and we should tout that. We should toot our horns, and we should make sure they know we're here and that we know how to do it.
If anybody needs help learning to toot your horn, call Amy. A great coach.
Horn tooting 101.
He really does it well. So we've had one question in the chat, Amy, from a colleague who just wanted clarification about the notarization. So just a reminder to people, actually, if you have questions, put them in the Q&A box. The Q&A box will appear if you move your cursor across the Zoom. But Amy, somebody was actually wanting clarification about the notarizing. And if I understood you correctly, what you were saying was that many patients thought they still needed to get these documents notarized, and part of what was helpful was you could inform them that that wasn't necessary. You could just get witnesses there, and the documents were
perfectly legal.
Yeah, there we go. That's the phrase.
Yes, absolutely. And I think that that's true everywhere. I know it's true in the state of Ohio that the two witnesses can really be anyone. They just can't be the person's primary physician. It can't be the owner of the nursing home where the person resides, for pretty obvious reasons, I would think. And they can't be the people that are named as surrogates on the document itself. So really, it's an ideal setting to do it in the hospital when they're doing registration, because again, you've got a front end health unit coordinator or a secretary or someone who's probably seen or met this patient at least once before. And you're not even vouching for the fact that they've got their patient ID number, their badges, their stickers, you know, you're just vouching that this person is who they say they are. And you're signing it that you saw them sign this paper. So that was exciting for people to realize it could be done quickly.
Great, Amy, thanks. I love your little sign here. And now we're moving on. Actually, my colleague, Director of Spiritual Care and Mission at Rush Oak Park, did a wonderful project about advanced directives in a physician's office adjacent to the hospital. Aoife, welcome. Aoife's picture, by the way, is on the second slide, but she doesn't have video today. But Aoife, welcome. Tell us about your project.
Thanks, George. Okay, Michael, we can go to the next slide. So as George has said, I'll just reiterate that I'm in a small community hospital, which is on the outskirts of Chicago, and we are part of Rush Healthcare in Chicago. And employed by the hospital are a number of physicians making up different groups, and it's one of those physicians whose office is in the building next door to the main hospital, the medical office building, and that's the doctor I was working with. So my project came out of the Coleman Palliative Medicine training program that I was involved with, and that was a training program that ran part-time over 2 years. It was interdisciplinary, so we had social workers, chaplains, nurse practitioners, and physicians training together. And part of the training requires that we had some sort of a project. So like many of those who are listening today, I have many years working as a chaplain and talking with patients, or more often their families, trying to in the ICU, trying to figure out what would the patient want and would not want. And so my project then wanted to take that conversation, as we know it's better to have it as far away from the ICU as possible. And I thought, well, let's see if I could do it in the physician's office, when somebody came in to see their doctor, walking and talking, and hopefully we're going out walking and talking as well. My goal was to begin values-based decision-making conversations. So thinking in a palliative mode, I'm looking at a palliative approach to people who have life-limiting conditions, and how do we start a conversation around from a palliative approach to look at what they might want as their condition progressed. That was kind of in the background of my mind. And then, of course, we wanted to document that because that's always helpful. So it will encourage conversations too. The documents, like Amy was saying, would help to focus conversations for the patient with their loved ones when they got home. And then, as I say, put all of that in the electronic medical record in EPIC. Thanks, Michael. The next slide. So in order to do this, there were 3 areas in particular that is involved in the model, and I'm going to go into them. And that's the relationships that I think is a very important part. Again, I think Amy has alluded to that too. It's an important part that we work as a team in this area, particularly when we're with patients and family. We have a team approach to what's best for them and helping them to make choices. Involved in that is technology, and then the actual advanced care planning process I'm going to look at. I think I'm going to leave the Medicare piece for the Q&A at the end. We'll get back to that. I'm going to try and stick to what I had to do in order for the model to be set up for the Coleman palliative medicine training purposes. Next slide. So, relationship. Again, I'm about 12 years here at Rush Oak Park Hospital. I had worked before that at Rush. And so I've been on the ethics committee here at the hospital. I co-chair it with a different physician, but this physician has been with me on that ethics committee. So we have a mutual trust, appreciation, and respect for our work and our person. And I think it's important too, we both share similar palliative care values. As you know, sometimes physicians aren't necessarily on the same page as, they're not all necessarily on the same page, and sometimes that can be very difficult for families when they start getting mixed messages. So I want to make sure that the physician I was working with, Dr. McGuinness, and I were comfortable with each other's way of thinking and being in relation to patients and families. She is a long time, longer than me, working in the Rush system, and she is beloved. She is primarily now a family practice physician. I think she started out though as a pediatric physician, but she's much loved by her patients. Next slide, Michael. So behind the scenes, it's really important. I had a lot of work to do with our EPIC staff in order to get the build up in EPIC so that I could actually chart in the outpatient setting. And with that, I'm also now a provider in this medical office. So this is an interesting piece to it all. So along with the physicians being providers, the nurse practitioner, and I'm now also a provider in the office. That also relates to a charting piece. And within that too, we wanted to be able to get some data out of EPIC, so it's important there. Charting in the outpatient is quite different than charting on the inpatient side. As chaplains, we all chart extensively on the inpatient side. Also important because was working with the different staff, and you know, I needed their help in order to get all of this process through. So the Office manager is an important person in all of this, and each member of the staff, from the person who schedules my visit to each one, the person who then scans the documents in. All of that, I think, was important. And if you go on to the next slide, please, Michael. The criteria for my seeing a patient, I established it. It's a research pilot project, so I had to limit it by my scope of the people I would see. So I decided on 70 and older. They had to obviously have decisional capacity if they were going to complete any legal documents. And we did not have any advanced directive already in their electronic medical record. The 70s piece, I sort of just picked out of the air, but part of me really wants to look at the older population because they often have had experience of having somebody in the ICU. I might come back to that a little bit more. So that was the first thing. I identified the patients to be seen. I ran those by the doctor. She said yes, and then I was scheduled. Then what happened was the patient would come in to visit the doctor. The doctor then would do her thing, and before the end of it would say, we have this project. I want to introduce you to the chaplain who is doing this, and will, if the patient was agreeable, then she would introduce me to the family. We did the meet in the exam room. So I go back to how important it is to have everybody in the office on board, because I was going to be slowing down a process of having two patients being prepped to see the doctor at a time. But they were all agreeable to this, and people have worked very well with me, even if it seems that I'm delaying the process a little bit. So it was nice to be in the exam room with them, because it was one-on-one, or me with a family member and with the patient. We had the door closed, so we had privacy, and the patient themselves didn't have to move from anywhere else. Initially, it was thought that they'd set me up in an office, but I think I would have had the same problems Amy encountered. You don't want to be moving a patient into a different room for a conversation, but easier to move me. So I also felt it was real important that I was introduced by the physician herself to the patient, because then there was a continuity of trust, a continuity of the conversation, and all of that setup helped people to go to the nitty-gritty of what is going to be a difficult conversation. I'll go back to this. It was a values-based conversation. I was looking to speak to folks about their experience, to see what their family makeup was, and as well as trying to narrow it down and getting them to name powers of attorney, also to name subs, to get as many names and phone numbers as we could. But for me, it was important that they looked at their own experience of loss of a loved one, or their experience of having a loved one in ICU or in hospice, and to how was all that, and to draw out from that, maybe bring in their own health concerns, and then to talk about their own wishes given their experiences, and also then to link those wishes with their faith and their values, and how those might influence their decision making. So that was the beginning part of my conversation, and then I would get into the DPOA healthcare document, which fortunately, I'd say more than 20 years ago, Rush has actually distilled to a one-page document that names the power of attorney, names the subs, and does have the basic questions of if do you want to be on life-sustaining treatment if the burden outweighed the benefit. If you were in a persistent vegetative state, would you want us to withdraw life support? Or did you want everything done? And so those are the three basic ABCs, or choices that are on the document. And people were, some were hesitant to actually make an option of one of those. That wasn't the goal of my conversation, as I say. The main thing was to get the power of attorney piece in terms of documentation. That was the important part. So after having done the document, then it was the front staff that scanned it in, and I gave the originals. And usually I gave at least the number of copies of subs or people that they had named on the document. So if there were 3 family members named on the document, the person got the original plus 3 copies, so that I could encourage them to share it with those people and to talk about their wishes and continue the conversation at home. For the people who didn't want to complete anything at that moment in time, all of them took a blank copy at the least. And again, to encourage the conversation at home. The next piece I said, oh, okay, and the results. So over the period of my pilot, I saw 60 patients. There were 60, I targeted 60, all agreed to see me and have the conversation. Of those, 80% actually completed advanced directives or had provided me with an advanced directive. And I think those were a couple of the Jehovah's Witness patients who often have a very small advanced directive in their purse or wallet, so that she said, I have one, and produced that. And then I photocopied that and scanned that into our electronic records, so we had it in there, and continued the conversation, and I would have documented. So in addition to scanning in the DPOA, I was able to document my intervention with the patient, and so put in a little bit of family history. Again, thinking of the future when I might be pulling up this person's medical record in 5 years' time, it'll be a prompt to me or to my colleagues to know something of the patient's thinking and their composition of their family or experience. Try to capture that in a progress note within EPIC. And 100% of the advanced directives were scanned into the medical record. We forgot to put the 100% in there. Okay, that's I think all I have for the moment. I will go back over to you, George, and we'll deal with the Medicare question when you ask me to.
Yeah, thanks. Michael, go back 2 slides to that last slide for Aoife's results. Friends, Aoife, thank you for the presentation. We really appreciate the story about your project and how successful it was. I want to call to your attention, actually, the little text box at the bottom of this slide, because we're really quite proud of the fact that after Aoife completed the project and we saw the kind of remarkable results, we decided to try to write it up as what's called a research letter for JAMA Internal Medicine, and they accepted it. So the kind of a brief report of what Aoife just described is in JAMA Internal Medicine. You see the title there, you see the link. It was published electronically a month ago. JAMA Internal Medicine, if you go on their website, you can download this article or any other article without a subscription, so you get to see the story. And if somebody, you're getting in a conversation with somebody about, whether or not chaplain care, whether or not chaplains can actually work in a physician's office, and will patients accept the invitation to have a conversation with a chaplain, and will those conversations actually be effective in increasing documentation of patients' preferences for care at the end of life? And, one study is not definitive, a small research letter is not definitive, but it's certainly very important beginning evidence, and we're really quite proud of that and excited about that. So, Michael, we are going to go to the Q&A, and I'm going to open this Q&A box and see if I can make it work. This is my first time with this technology. And I see some questions here. Allison Kestenbaum, San Diego. Allison, good to have you with us. Was there any pushback or collaboration from other disciplines that see advanced care planning as part of their role? so Aoife wasn't competing with anybody in that physician's office about that. The physician could have been doing some of that work, but she was actually glad to have Aoife help with it. Amy, what about you? Were you?
Absolutely not. In fact, I would have loved it if other people wanted to do it. We had the opposite problem that our social workers, almost all of our social workers throughout the clinic are completely absorbed now with discharge planning. So even when, I mean, they will do it when asked and requested to do it, they will obviously do it, but they did not want to feel like that was going to be an added expectation on their duties. Front end people nervous about it, didn't want to do it. Most people had the opposite feeling, like, oh, thank goodness somebody wants to take care of this.
Thanks, Amy.
I would echo as Amy is saying. In fact, there are four physicians in this particular practice, and I was only dealing with one. The other three kind of felt left out, and they would all want a chaplain there. They would just love to have a chaplain in the office having these conversations with people, and no wrestling for it at all. The other piece, and I'm not sure if it came up earlier, but in terms of witnessing the durable power of attorney for healthcare, in the RUSH system, and I don't know, Amy, if this is true for Cleveland, in the RUSH system, it is the general policy is that employees do not witness legal documents unless they are clearly hospital related. And the power of attorney, witnessing of a power of attorney for healthcare has fallen to chaplains, not to our social workers, but to chaplains. So in all my years at Rush and Rush here, Rush Oak Park, it's been the chaplains that actually are seen as the official people on behalf of the system to witness the document. And that, I think, is interesting in itself, because the physician can have the conversation, but they actually can't execute the document.
Correct. Yeah, we had the same. We would be one of the two witnesses, and then we would get usually someone else that was on the team to do it. Not a family member, obviously, and not somebody named in the document. But the people seemed actually comforted, and we haven't run into any troubles. I think we would have heard that by now if that had been an issue.
Yeah.
They are two Cleveland Clinic employees, one of them being the person that helped them fill out the documents, i.e. the chaplain. So we had the same thing.
We actually only need one witness for the DPOA.
Oh, we need two in Ohio.
The living will needs two witnesses, funnily enough, but I didn't deal with the living will at all, just the DPOA.
Interesting. We needed two for both in Atlanta.
All right. Let's not get down into the weeds about the witnesses. I'm cutting this off. But we do have a number of questions, actually, or comments from colleagues about the fact that state by state, there are variations about notarization requirements, whether or not DPOA is required. So thanks, colleagues, for your reminders about that. I think chaplains are aware that some of these things vary state by state, and you do need to be aware of your state requirements and adhere to them. But we've got a couple here that are getting to one of the things that is in a kind of key piece of the background, particularly for the work that Aoife did in Dr. McGinnis's practice. So Aoife, I'm going to throw these to you together. There's two of them, one from Thomas Backer, the other from Kevin Hickey. Thomas is asking, who paid for the chaplain's time in the Rush Medical Clinic during that study? And Kevin is asking, in the Rush pilot, are the physicians billing for the chaplain discussions? And if so, do you see any ethical or professional concerns? So Aoife, do you want to take those on?
Sure. The first one, nobody paid for by doing it. In a sense, it was part of my Coleman palliative medicine training, and I had the backing and support of my chief medical officer and my senior administration. Were very happy that I was engaging in palliative training. I'm as I said before, I co-chair the ethics committee. I'm very much seen as the resource person in relation to palliative care here. We do not have palliative care physicians at Rush Oak Park Hospital. They have a palliative care service in the big house down in the city, but out here in the suburbs we don't. So I have institutional support to allow me the time to go do this IFA. It's a great pilot, and whatever you do is wonderful. And so it's all, so there's no direct pay in that regard. So the second question relates to the Medicare payment piece, and that actually has been interesting, to say the least of it. So initially, the pilot, as I said, was a limited period of time, was done in 2016, and I was asked by my CMO if I would continue it and work actually a little bit more. And so we started looking at the Medicare requirements, therefore, for the billing purposes. So those requirements we thought we had met, and in fact, I was doing that, and I have begun working more so in the doctor's offices. And now, yes, there was a part of my salary was being coming out of the physician group budget, and I was given extra support, so continue to guide what was going on in the hospital, so the work in the hospital wasn't going to fall behind because I was over in the medical office building. And that's primarily, primarily the whole thing is happening because of the institution value the intervention of having these conversations as early on as possible. And I think more and more that is coming to the fore. The fact that then billing could occur through the physician was also a carrot, a good carrot. But our compliance are really looking and reassessing, and we seem to have they put a bit of a freeze on the billing side. So in fact, Medicare has paid for what some of the visits that I have done in more recent times, because I've made my visits, let's see, we've extended them in order to be sure that they meet the Medicare requirements. And one of those is that the conversation that the physician or the physician's representative, professional representative, has is it lasts at least 16 minutes, or otherwise you can't bill for it. So there's 16 to 30 minutes, and then there's 31 minutes to 60 minutes billing codes that are involved. The other piece then is how that's all charted. And I was charting and then forwarding it to my physician, who then incorporated my chart note into their chart note, and there's a lot of detail there that's involved. So all of that was happening. Medicare has actually paid out in some of this, but our legal people have started to look at it, and the question is coming down to who is considered a qualified medical professional. And in their understanding of that, it is only the physician or a nurse practitioner, even if it is incident to, i.e. my going in to see the patient is linked to their already existing doctor's appointment and seeing of the doctor. But they're saying basically it's this understanding of what constitutes a professional healthcare person. And at this moment in time, they're saying chaplains and social workers, because our social workers in palliative medicine were also doing these conversations, but both of us are now, there's a question mark over whether we're being recognized. So the billing piece looked like it was sorted out, and now there's a freeze on it. So it's in process.
Thanks, Aoife. So, friends, I'm not sure if you followed all of those details in terms of what Aoife said. I mean, the bottom line is that in the pilot project, she was doing that as part of a quality improvement effort, and her time she was released from the inpatient work to do that. once the administration of her hospital saw the success of that, they've actually supported her department, given the department some extra resources for inpatient care, and released IFA to do more work in the outpatient around advanced directives. And the initial interpretation from the billing and people at IFA's hospital was that, in fact, IFA's work under the doctor's supervision, documented the way IFA described, would actually be reimbursable, and some of it has been reimbursed. But then some other people in the hospital and legal affairs and compliance have taken another look, and they're less clear whether or not the chaplains qualify. Chaplains doing these interventions under physician supervision qualify for reimbursement. So they're taking a second look at that. But I'm going over what IFA said again, in part because the details are a little bit, things that we're not all used to. We have found a very good reference article about this, and unfortunately, I forgot to put that reference in the citations for the slides. But we will get that out to you and be sure it's posted, so those of you who want to get into some of these details can see the article that we've used for some guidance on this. But we'd also love to hear from any chaplains who are, in fact, trying a similar experiment as the experiment IFA had, where the chaplains are conducting these advanced care planning conversations under physician supervision, and they're considering, or in fact already are, seeking reimbursement for the chaplain's time for that. So we think it's a pretty important kind of cutting edge for the profession. That's part of why we wanted to present it in this kind of strategic thinking series of webinars. So if you are involved in similar projects, and you can pass on any information about whether or not you have sought reimbursement and it's been approved, or sought reimbursement and it's been declined, we would love to hear from you about that. You could just send me an email, or send the email to Transforming Chaplaincy to Catherine Lyons, our project coordinator, and we'll try to compile that information. And again, want to remind people that, IFA's project really was kind of striking in what it found. It was a new context for chaplains' involvement, being in the physician's office, and so we were able to kind of write a brief letter about it, get it published. Amy was busy doing 1,000 other things, and they had the Republican convention in town at the same time, so they didn't have any time to write that up. But it's the projects like that Amy's done, that IFA's done, that some of you who are on this call have done, that we do need to kind of write up. They don't have to be big, full articles. We can use this kind of brief report approach and get them into the literature. That'll be helpful for all of us, I think, as we try to move ahead on this. So Carolyn Grant, Carolyn has a question. Was the chaplain added as a provider in the MD office in IFA's project, so Medicare would pay for the chaplain's time? And that's exactly right. That's exactly why they were taking that approach. Thomas Becker has a question, and we maybe have time for one or two more on the Q&A. So if you have another question or comment, go ahead and type it in. But Amy wants to know, what's a pre-anesthesia clinic?
It's a special clinic where they come before their surgery. So usually about a week before major surgery, and especially if, I guess, maybe some higher risk cases. I'm not exactly certain. I think it's just the visit they make before they have a serious surgery usually about a week out. So they're doing, they're doing lots of different tests and just prepping them for what's coming. It seemed like another person had asked about demographics, and I think it wasn't primarily the elderly, it was really everybody. So we have a couple of them here, and I don't know if it's just a clinic thing to send people through another whole set of tests and information gathering before they go to surgery. And I don't think they would do it with everyone, but that's what it is. And the assumption was that with surgery coming, but not that day, people would be maybe open to talking about it, but not, imminently nervous or frightened about it. Hope that answers. I think you can look up information about pre-anesthesia clinics on online. I hope that helps.
Amy, actually, Ardella Gibson is actually kind of related, a related question. Ardella wants to know what the physician's specialty was. Dr.
Koifman,
Kreuzman, who approached you. Yeah.
radiation oncology. So he had seen a lot of his patients don't end up doing all that well, and this is very near and dear to his heart.
So there's a comment here from James Robinson. James is saying he's going to write up their experience in the NACC newsletter.
Great.
Coming out next month, March, April, and Vision. So James, I'm glad to hear about that. I look forward to seeing it. One of the problems we have being a profession where we have multiple organizations is that we don't see each other's newsletters. So how are we going to get that information out to a wider audience? Can you send us a heads up or send us a link so that people who want to know what you did and what you learned, we can actually, if we can link to the NACC Vision articles, we'd certainly be happy to do that off the Transforming Chaplaincy website, or some of you will know the Transforming Chaplaincy. We do social media pretty intensively, and Michael, who's in the background here helping us today, is our social media and website guy. So, by all means, if you have information about projects that you're developing or doing, by all means, let us know about that, because we want to use Transforming Chaplaincy to get the word out about those things. We're coming down the home stretch here, and I'm actually going to kind of wrap up and finish with the Q&A, if you all don't mind. And Michael, let's just look at the last slide. Today's session is one of 3 free webinars Transforming Chaplaincy is producing with support from our colleagues at ACPE that are designed to help chaplains learn to think and act strategically. We're very good at the bedside, and we're very good, as Amy said, about kind of helping patients and families talk about difficult things like advanced directives, but we're not the best people to think and act strategically related to the profession. So our kind of series this year, today was the first one. The second one you'll see here will be on April 2nd. And the focus of that webinar will be on return on investment. So, what's the value of chaplaincy care? For all the dollars we put into chaplaincy care, what are we getting back out of that? So I'm sure those of you who are chaplains or chaplaincy managers have kind of heard those questions. And we don't, as a profession, have good ways to think about them or respond to them. But our colleague Mark Grace down at Baylor has actually collaborated with some research colleagues at the Institute for Religion at Baylor, and they have produced a wonderful document about return on investment. And so that will be the next webinar, session 2. The background document that I just referred to that Mark's colleagues produced for him is available as a free download. And if you go to the ACPE website to register for either of these next 2 sessions, the link to the document that Mark's colleagues produced for him is available, so you can download that in advance and read that and study that. And there'll be an exam actually after that webinar, so you better be studying carefully. The third webinar this year will be on May 17th. You're all familiar with the ways in which healthcare organizations are thinking about being accountable care organizations, being healthcare homes, being interested in supporting population health. All of that's going to mean more and more of healthcare is going into outpatient context, focusing on wellness context, and we have very little good thinking about what that means for spiritual care. So we're really pleased that Tim Glover, who's the Senior Vice President for Mission Integration in Ascension Healthcare, the largest, I think, Catholic healthcare system in the United States, will be joining us for a conversation about what he thinks some of those changes and challenges will mean for spiritual care. So we, both of those sessions, by the way, 1 o'clock, 60 minutes Central Time. And again, you can register at the ACPE website. Thanks to everybody for today. Thanks to our presenters, Sunita at IU Health, Amy in Cleveland, Aoife in Oak Park, John, Michael for kind of helping us run the website, John, and Carl in Atlanta, thanks for your help. Friends, if you have comments or questions, send them to us at Transforming Chaplaincy. We'd love to hear your feedback and do what we can to help the profession learn to think and act strategically. Have a good day, friends.
Bye.